Usually when we talk about a medical diagnosis, there is this expectation of absolute, undeniable precision.
Right, like it's a math problem.
Exactly.
Yeah.
It feels like engineering. You break your arm falling off a bike, you go in for an x-ray, and there's that, jagged white line on the film.
It's very black and white.
Yeah, the doctor just points to it, and you have your answer. Broken or not broken, it's a clean, binary reality.
And, we really crave that kind of visual confirmation.
Well, for sure.
It provides this psychological comfort, to see a physical defect, categorize it, and just apply a mechanical fix. But the moment you step into the realm of human biomechanics,
Especially the back.
right, specifically the human spine, that comforting X-ray machine effectively breaks down. You enter this landscape of diagnostic murky waters where the picture, well, it rarely tells the whole story.
Which is exactly why you are here with us for this deep dive. Today, we are taking an exhaustive look at the medical insights presented by Dr. Christophe Delong and the Kinexa Formation.
It's really fascinating material.
It is. We are using their clinical frameworks to completely dismantle, everything we assume to be true about what they call the malady of the century, which is back pain.
Yeah.
So if you have ever winced trying to get out of a low car or, spent a fortune on one of those ergonomic office chairs hoping for a miracle cure, you really need to hear this.
Because the goal today is to strip away the cultural folklore, the old wives' tales, and honestly, the marketing gimmicks.
There are so many of those.
Too many. We are going to look at the raw anatomical, psychological, and biomechanical realities of how the spine actually functions. Because what the clinical science demonstrates is, well, it's wildly counterintuitive to the stories we tell ourselves about pain.
I promise you, by the end of this conversation, you are going to understand why the command to, sit up perfectly straight at your desk is actually an anatomical myth.
A huge myth.
And you will learn why feeling unappreciated by your boss is a stronger predictor of a bad back than a degenerating disc.
That's the one that always shocks people.
It blew my mind. And you'll find out why the simple, mundane act of leaning over your bathroom sink to shave puts a staggering 150 kilograms of pressure on your lower spine.
It's just wild physics.
Let's start with the narrative we all just kind of accept as fact, right? That back pain is this uniquely modern curse.
Right, the whole we weren't meant to sit in cubicles thing.
Exactly. The story goes that because we abandoned our hunter-gatherer roots to stare at screens all day, we just ruined our spines. But looking at the historical data presented by Dr. Delong, that narrative completely falls apart.
It really does. The idea of back pain as a byproduct of modern sedentary life is, honestly, it's nothing more than a comforting fiction.
It sounds good, though.
It does. It taps into this romanticized notion that if we just return to some idealized natural state of constant motion, our bodies would be flawless. But the medical literature throughout recorded history tells a vastly different, much more painful story.
Like the ancient texts. Right.
Oh, absolutely. The ancient Chinese medical masters devoted entire treatises to debilitating spinal ailments. And Galen, the preeminent physician of the Roman Empire back in the 2nd century, he documented severe chronic lumbar pain in his patients.
Wow.
Yeah. And fast forward to the 16th century, and you have Ambroise Paré, who is basically one of the foundational figures of modern surgery, dedicating massive amounts of time trying to devise treatments for agonizing back spasms.
So it's definitely not just from looking at smartphones, and it wasn't just confined to medical texts either. The historical overview notes that literary giants were completely preoccupied with it.
They really were.
Yeah, Molière, Shakespeare, Honoré de Balzac, Guy de Maupassant, they routinely wrote characters who were just paralyzed by a severe lumbago and sciatica.
Right.
But the analysis points out something truly fascinating about why it was such a prominent theme in literature and high society.
Yeah.
It is described as an elegant complaint.
Yes.
What makes a throbbing lower back elegant?
Well, think about the intense social taboos surrounding the human body, especially in past centuries, but honestly, even today. The back operates as a socially neutral zone.
Oh, I see.
Right. If you are at a dinner party, it is entirely acceptable, even an avenue for bonding, to complain about a stiff lower back. It elicits sympathy.
Yeah, everyone chimes in with their own backstory.
Exactly. Conversely, it is socially fraught and often deeply stigmatized to express suffering in other, more intimate parts of the body. And even more difficult is admitting to a profound drop in morale, crippling anxiety, or, a failing marriage.
That is so true.
The back serves as a highly convenient, universally understood scapegoat for a broader, generalized pain of living.
That makes profound sense. Saying my back is killing me
Yeah.
is basically a socially sanctioned proxy for saying my life is entirely overwhelming right now.
Spot on. It allows the patient to seek care without violating modesty or admitting to psychological distress. And, it gives the doctor something physical to examine.
So if the sheer existence of back pain hasn't changed over the centuries, what about our actual bodies? Because the data on human growth is staggering.
It really is.
In the last century alone, the average French person has grown 14 centimeters. That is a massive physiological shift in a very short evolutionary window.
Huge.
So how does a sudden increase in height affect the mechanics of the spine? It seems logical that, a longer spine would mean more leverage and therefore more strain, right?
That is a highly prevalent assumption. People look at a taller individual and assume the elongated lever arm of their spine makes them inherently more fragile.
Yeah, you always hear tall people complaining about their backs.
Sure, but the clinical data actually contradicts that logic. Height itself is not the culprit for chronic back pain.
Really?
Yeah. We do see a specific localized issue called Scheuermann's disease, which primarily occurs during adolescent growth spurts.
Okay.
So when a teenager shoots up in height very rapidly, the growth plates of the vertebrae can sometimes fail to develop evenly.
Oh, so they grow kind of lopsided.
Exactly. The vertebrae can actually grow into slightly wedge-like shapes instead of flat cylinders. And that leads to a permanent, slightly exaggerated forward curve, a kyphosis, which can cause recurrent pain later in life.
Ah, I see.
But when you remove that specific developmental anomaly and look at generalized chronic back pain in the adult population, it strikes the exceptionally tall and the incredibly short with total equality.
Wow, okay. So if the length of the spine isn't the primary variable, then we have to look at the pure physics applied to it.
Right.
And here's where it gets really interesting, because the biomechanical numbers in this research absolutely floored me. I don't think any of us comprehend the sheer mechanical force our bodies are subjected to just by, existing in gravity.
We really don't.
We need to talk about the L5-S1 disc. This is the very last intervertebral disc at the base of the spine, sitting right between the fifth lumbar vertebra and the sacrum.
Yeah, that specific disc is basically the primary shock absorber and pivot point for the entire upper half of the human body.
The measurements of pressure on that specific disc are mind-boggling. When you are lying completely flat on your back, supposedly at total rest, there is still 25 kilograms of pressure bearing down on that L5-S1 disc.
Just from the resting tension of the muscles and ligaments.
Which is wild. But then, the moment you stand up straight, that pressure doubles to 50 kilograms.
Right.
But here's the part that makes zero sense intuitively to me. When you sit down in a chair, which is an act we universally associate with resting and taking a load off, right?
Yeah.
The pressure on that lower disc skyrockets to 140 kilograms. How is sitting 3 times more physically punishing than standing?
It comes down to the loss of natural structural alignment and the shifting of the pelvis.
Okay, walk me through that.
So, when you stand upright, your spine maintains its natural S curve. That curve acts like a coiled spring, distributing the downward force of gravity evenly across multiple vertebrae and discs, as well as the hips and legs.
Makes sense.
But the moment you sit down, your pelvis tilts backward. That natural shock-absorbing lumbar curve flattens out or even reverses.
So you basically lose the spring entirely.
Precisely. You disable the body's natural shock distribution system.
Wow.
All of the weight of your torso, your head, and your arms is no longer dispersed down through your legs to the floor. It is driven straight down, culminating in a massive, concentrated point of sheer force directly onto the L5-S1 disc.
Wait, I'm visualizing this. It's exactly like a massive construction crane.
Yes.
If the vertical power of a crane is perfectly plumb and straight, the weight is driving straight down into the foundation, so it's incredibly stable.
Right.
But if you tilt that towering arm even a few degrees forward, the leverage creates a massive multiplied amount of pressure at the very base to keep the whole structure from tipping over and ripping out of the ground.
Exactly.
So our spine is the crane tower, And the lower back is the foundation trying to hold it all upright.
That is a flawless biomechanical analogy, and it perfectly explains the next set of data regarding everyday movements. Because the spine isn't just dealing with static weight, it deals with dynamic leverage. When you stand at your bathroom sink and lean just a few degrees forward to shave or wash your face, you are tilting the crane. That slight forward angle multiplies the force on the L5-S1 disc to 150 kilograms.
Just leaning over the sink.
Yes. And if you bend straight over from the waist without bending your knees to pick a light object off the floor,
Oh boy.
the lever arm is fully extended. The counterforce required by your lower back muscles to pull you back up results in 300 kilograms of compressive pressure on that lower disc.
300 kilograms of pressure just to pick up a dropped pen. That is literally the weight of a large motorcycle compressing a piece of cartilage the size of a marshmallow.
It's terrifying when you put it like that.
It's a miracle we can walk at all.
It highlights how relentlessly the spine fights gravity. The forces compressing and dehydrating your intervertebral discs are vastly disproportional to your actual body weight or the weight of whatever you might be lifting.
Yep.
Your lower back is acting as the fulcrum, lifting the entire upper half of your body against gravity, multiplied by the extreme leverage of your reach.
So under that immense invisible load, things are inevitably going to break down. Let's dig into the actual anatomy of the ache.
Okay.
When that biological crane creaks and the pain hits, what is physically failing? Because the universal cultural reaction to a sudden sharp pain in the back is to say, oh, I pinched a nerve.
Right. Everyone says that.
Someone twists wrong, they feel an electrical spark or a jolt of pure agony, and they immediately self-diagnose a pinched nerve.
And overwhelmingly, they are completely incorrect.
Really?
Yeah.
Okay.
A genuine mechanically pinched nerve where a structure is actively crushing nerve tissue is statistically quite rare.
Then what exactly is that terrifying electrical jolt? Because it feels distinctly neurological, like a shock.
That sensation is almost always the result of a severe sprain or a muscle tear.
Like a sprained ankle.
Exactly like that.
Yeah.
We readily understand that if we step off a curb wrong, we can sprain our ankle by stretching or tearing the ligaments that hold the joint together. The spine is no different. It is encased in a complex, overlapping web of tiny, incredibly strong ligaments that connect the vertebrae, limit our range of motion, and maintain structural integrity.
Sure.
A sudden, jerky movement, lifting an awkward load, or even maintaining a poor posture for too long can stretch those tiny spinal ligaments beyond their elastic limit, causing micro tears.
So a bad back is often just a sprained ankle, but located in the spine.
Mechanically, yes. The reason it feels like a localized electrical shock is due to the body's immediate defense mechanism.
What happens?
The moment that ligament tears, the nervous system detects catastrophic instability. To prevent you from moving further and potentially severing the spinal cord, the brain sends an emergency signal to the massive muscles surrounding the spine, the paravertebrals.
Oh, I see where this is going.
Those muscles instantly go into a violent, rigid spasm. They clamp down with immense force to essentially create an internal biological cast, freezing the area in place. That violent muscle clamp is the sharp, breathtaking agony you feel.
Wow. That completely reframes the entire experience. We treat our backs like delicate glass that is shattered, when really it's just our muscles violently trying to protect a minor tear.
Exactly. It's an overreaction in a way.
But when the pain doesn't go away, we eventually end up in front of an x-ray machine. And doctors tend to use terminology that sounds incredibly dire.
They do.
The clinical frameworks we are looking at specifically highlight the confusion between two very distinct diagnoses. There's pincement discal and tassement vertebral.
Right, French terms that often get mixed up.
Yeah, pincement translates to disc narrowing, and tassement means vertebral compression. To a layperson, narrowing and compression sound like the exact same thing.
Lexically, they are similar, sure, but structurally and clinically, they describe two entirely different forms of degradation. Let's look at the pincement discal, the disc narrowing. This is essentially the wear and tear of the shock absorber itself. The intervertebral disc is made of fibroelastic tissue. It has a tough, fibrous outer ring and a gel-like inner core, highly dependent on water content to maintain its viscoelasticity.
Wait, can we pause on that term? What does viscoelasticity actually mean in the context of a spine?
Think of it like a brand new, highly saturated kitchen sponge.
Cool.
If you place a heavy book on it, the sponge deforms, but the water inside provides resistance. When you remove the book, the sponge immediately springs back to its original shape. That is viscoelasticity.
Got it.
But cartilage has very poor blood supply. It relies on the pumping motion of movement to imbibe water and nutrients. Over decades of bearing those 300 kilogram sheer forces we talked about, the disc slowly dehydrates.
That dries out.
Exactly. It goes from a wet sponge to a dry, brittle sponge. It flattens out permanently.
Okay.
Because the disc itself contains no calcium, it is entirely invisible on an X-ray.
Oh.
The doctor simply looks at the film, sees the white squares of the bones, and notices that the dark, empty gap between them has shrunk.
So the cushion has just lost its air, basically. That sounds relatively normal, honestly.
It is incredibly common even in highly active people in their early 30s who have subjected their spines to heavy loads or hyperextension in sports.
Right. What about the other one, the attachment?
Attachment, on the other hand, of vertebral compression is a vastly more severe event. This is an actual structural bone fracture. The vertebra itself, the solid block of calcium and trabecular bone, physically collapses under pressure.
The scaffolding itself breaks, not just the cushion. How does the solid bone just collapse?
We typically see this in older demographics suffering from advanced osteoporosis, where the density of the bone has become so porous and brittle that it can no longer support the body's weight.
That makes sense.
We also see it frequently in patients who have undergone prolonged corticosteroid treatments.
Oh, really?
Yes, corticosteroids are incredibly effective at suppressing inflammation, but long-term systemic use actively inhibits osteoblasts, which are the cells responsible for building new bone. Meanwhile, it allows osteoclasts, the cells that break bone down, to continue working, so the bone literally hollows out from the inside. When it finally gives way, it often collapses unevenly, taking on a wedge shape, which forces the entire spine to curve sharply forward.
Okay, that is much more serious. We need to dive into another terrifying diagnosis that dominates the conversation around back pain. The herniated disc.
The famous slip disc.
Yeah. Structurally, we are taught that a herniation happens when the outer wall of that spinal cushion cracks and the inner jelly violently pushes out into the spinal canal.
Right.
Is portrayed as a physical, mechanical obstruction. Yet, the absolute standard first-line medical treatment for herniated disc is a prescription for anti-inflammatory medication.
Yes, it is.
So let's unpack this. If a disc slips out, how does swallowing a chemical pill force a physical piece of cartilage to magically suck back inside the disc?
The short answer is well, it doesn't.
It does.
No. And understanding why forces us to completely reevaluate how the human nervous system interacts with physical damage. The pill does not repair the crack, and it does not push the jelly back into place.
Then why on earth is it the first-line treatment? If the bulge is still there, why does the pain go away?
We have to look at a statistical reality that usually stuns patients. If we took a massive randomized sample of the general population, people who are walking around playing sports and recording absolutely zero back pain,
Okay.
and we put them all through an MRI machine, we would discover that roughly 30% of those perfectly healthy, pain-free people have physically herniated discs.
Wait, really? 30%?
Yes.
Almost a third of the population is walking around with ruptured spinal discs, and they have absolutely no idea.
Correct, which proves that the mechanical presence of expelled cartilage touching a nerve is not the primary generator of the agony associated with a slipped disc.
Then what is?
The excruciating, paralyzing pain comes entirely from the chemical cascade of inflammation.
Oh, the swelling.
Exactly. When the inner core of the disc ruptures into the spinal canal, the immune system detects biological material in an area where it does not belong. It assumes an injury or an infection has occurred and launches a massive inflammatory response. Macrophages rush to the site, cytokines are released, and the surrounding cellular tissue violently swells up. It is this sudden, acute swelling of the surrounding tissue that effectively chokes the nerve root, like the sciatic nerve, causing the radiating agony down the leg.
That is mind-blowing. The disc material isn't crushing the nerve. Your own immune system's swelling is crushing the nerve.
Exactly. So when a physician prescribes a heavy course of non-steroidal anti-inflammatories or administers a targeted corticosteroid injection, the goal is purely chemical.
To stop the swelling.
Right. The medication blocks the production of prostaglandins, halting the inflammatory cascade. The swollen cells shrink back down to their normal size. The compression on the nerve root is completely relieved, and the pain evaporates. The physical chunk of herniated cartilage is still sitting right there on the MRI, but your body eventually degrades it or simply adapts to navigate around it. You are treating the biochemical reaction, not the mechanical defect.
That completely upends how we should think about our bodies.
Yeah.
We're so obsessed with the mechanics, put my back into place. when we really should be focused on the chemistry.
Exactly.
But speaking of things being out of place, the insights from Dr. DeLong and the Kinexa Formation spend a significant amount of time exploring how the back often acts as a massive alarm bell for diseases that have absolutely nothing to do with the spine.
Referred pain, it's a huge topic.
Right. The human nervous system is an incredibly dense overlapping network. It is not a series of isolated wires running to a single control board.
No, it's highly complex. Visceral nerves, which innervate our internal organs, and somatic nerves, which innervate our skin and skeletal muscles, often converge and enter the spinal cord at the exact same segment.
So the wires basically get crossed.
Precisely. Because the brain receives sensory input from the skin and muscles constantly, but rarely receives pain signals from internal organs, it operates on a statistical probability.
Oh, that's interesting.
Yeah. When a distressed organ sends a severe pain signal up a shared nerve pathway, the brain often misinterprets the origin point. It defaults to assuming the pain is coming from the familiar muscles and skin of the back.
The examples in the clinical data were terrifying to me. A patient could experience a sudden, stabbing pain directly between their shoulder blades, and it has nothing to do with lifting a heavy box.
Right.
It could actually be a bleeding stomach ulcer, or it could be acute gastritis. It could be pleurisy, which is an inflammation of the lining of the lungs. The back is literally screaming because the stomach or the lungs are failing.
Or, most critically, it can be the atypical presentation of a myocardial infarction, a heart attack.
A heart attack from back pain.
Yes. A clinician presented with a patient suffering from acute, unexplained mid-back pain cannot afford a tunnel vision approach. They must act as a diagnostician and rule out these life-threatening, visceral, internal organ failures before they can safely assume it is merely a musculoskeletal strain.
It's not just the internal organs projecting pain either. The text explores how other joints play tricks on the spine. The shoulder connection is fascinating. You can wake up with an incredibly stiff neck, unable to turn your head, accompanied by burning upper back pain.
And you'd assume you slept wrong on your neck.
Exactly. But the actual injury is often tendonitis in the rotator cuff of the shoulder.
Right. The body operates as a kinetic chain. The trapezius muscle, for example, is a massive kite-shaped muscle. It anchors across the entire width of the shoulder blades, but its upper fibers attach all the way up into the base of the skull and the cervical spine. So, if the rotator cuff in the shoulder joint is inflamed and dysfunctional, the trapezius muscle has to engage and lock down to protect the injured shoulder. Because that muscle is anchored to the neck, the massive tension radiates all the way up the chain.
It's like pitching a large canvas tent.
How so?
Well, if the tent pole on the left side is unstable, the canvas pulls incredibly tight, and it might actually tear the fabric on the completely opposite side of the tent. The physical damage happens on the right, but the root cause is the unstable pole on the left.
That is a brilliant way to visualize the fascial and muscular connections of the body. We see this tent pole phenomenon constantly with the lower body, specifically the hips and the knees.
Oh, really?
Yes. Let's imagine a patient who has developed advanced arthrosis or osteoarthritis in their knee joints. The cartilage has worn away and bearing weight on straight legs is painful. Subconsciously, the patient will adopt what we term an antalgic posture. They begin to walk with their knees slightly bent, leaning their torso slightly forward to alter the joint angle and avoid the bone-on-bone friction in their knees.
Wait, if they're leaning forward, we are back to the construction crane analogy.
Exactly.
If their knees are bent, their center of gravity is completely pitched forward. They are constantly in a state of almost falling on their face.
Exactly. And the only thing preventing them from tumbling face first into the ground are the paravertebral muscles of the lower back.
Because they have to pull back.
Right. Because the center of gravity is off, those lower back muscles have to fire continuously, essentially working at maximum capacity all day long just to pull the torso backward and keep the patient upright.
So the back muscles are running a marathon every single day without the patient even exercising.
And eventually, those back muscles hit a state of total metabolic exhaustion. They seize up into massive debilitating spasms. The patient hobbles into the clinic complaining that their back is destroyed.
But it's not.
Structurally, their spine is perfectly fine. The back is simply the exhausted victim of the failing knees. If a clinician merely treats the lower back with massages and heat packs, but fails to recognize and address the arthritic knees causing the antalgic posture, that patient will never, ever find permanent relief.
You cannot just look at the site of the pain. You have to look at the entire machine.
Precisely.
Now, considering how much work those back muscles are doing to hold us together, we need to look at how they recover. We spend a third of our human lives horizontal in bed. And the debate over mattresses is, well, it's practically a religion at this point.
It really is.
Do you need a rigid board? Do you need a cloud? The clinical consensus in the research seems to finally settle the debate, right?
Yes. The biomechanical data overwhelmingly supports a medium-firm mattress as the universal ideal for mitigating and preventing spinal pain.
Not the ultra-firm ones.
No. If a mattress is too soft, the heavier parts of the human anatomy, like the pelvis and the shoulders, sink entirely too deep. This pulls the lumbar and cervical spine out of their neutral horizontal axis, forcing the ligaments to stretch asymmetrically for 8 hours.
Okay, but what if it's too hard?
Conversely, ultra-hard surfaces or traditional futons demand a rigorous physiological adaptation period. While some cultures are acclimated to them from birth, introducing a rigid surface to an adult body accustomed to cushioning often leads to severe pressure point pain in the hips and shoulders.
But the research makes a critical point here. The mattress is only the physical half of the sleep equation.
Exactly. The psychological quality of your sleep plays an equally massive role.
Because if you go to bed ruminating on an argument or obsessing over financial anxieties, your brain remains in a hypervigilant state.
Right. It can't switch off.
It literally refuses to send the neurological all-clear signal to your muscular system. You maintain these imperceptible microtensions in your paravertebral muscles all night long. You wake up with an agonizingly stiff back, not because your mattress failed you, but because your anxious brain refused to let your physical body power down.
Which serves as the perfect transition into what is arguably the most complex and often the most misunderstood aspect of this entire field.
The mind-body connection.
Yes, the profound psychological reality of back pain. We often use the phrase, "my back reflects my mood," as a poetic metaphor, but from a clinical, biological perspective, it is a literal truth.
We all know that stress is broadly bad for us. But how does an invisible emotional state like stress physically reach out and lock up the bones and muscles of the spine? What is the actual mechanism?
It originates with the fight-or-flight response, governed by the sympathetic nervous system and the HPA axis, which is the hypothalamic-pituitary-adrenal axis.
Okay, that sounds intense.
It is. When you perceive psychological stress, say a looming deadline or a toxic interaction, your brain interprets it as a literal threat to your survival. It floods the system with cortisol and adrenaline. A key component of the survival response is the activation of the muscle spindles, preparing the physical body to either run for its life or engage in physical combat.
But we don't actually fight or run, usually.
Exactly. In modern humans, because we rarely actually fight or flee, this results in a permanent subconscious contracture of the musculature. And this tension tends to localize heavily in the jaw, the neck, and the shoulders.
It's the classic image of the stressed office worker typing furiously, with their shoulders hitched up so high they're practically touching their earlobes.
Precisely. Now consider the long-term mechanical wear that this invisible emotional tension creates. Cervical arthrosis, which is the natural degradation of the cartilage in the neck, actually begins to develop radiographically as early as age 25 in most adults.
Wait, age 25?
Yes. Usually it is completely asymptomatic, but when you overlay that chronic, grinding, stress-induced muscle tension onto those subtly worn cervical joints, the muscles effectively compress the fragile joints together. The result is severe, radiating pain down the shoulder blades, triggered entirely by psychological load acting upon normal anatomical aging.
This mind-body collision gets even more pronounced and severe when we look at complex conditions like fibromyalgia. The clinical frameworks we're reviewing dive into this.
They do, quite deeply.
Fibromyalgia is so often culturally dismissed as someone just feeling achy and tired. But medically, it represents a profound systemic neurological shift.
Right. It is a devastating mischaracterization to view fibromyalgia as mere fatigue. It is fundamentally a disorder of central sensitization.
What does that mean exactly?
The entire neurological threshold at which a sensory stimulus is registered as painful by the brain drops precipitously.
So things that shouldn't hurt start hurting?
Exactly. The central nervous system amplifies normal sensory signals, a light touch, a change in temperature, normal joint movement, and interprets them as excruciating nociceptive pain.
That sounds awful.
It is. This amplified pain is diffuse, migrating across multiple muscle groups, but heavily concentrated along the spine and the limbs. And importantly, it very frequently carries a strong depressive undertone.
The treatment protocols for this are fascinating, and they highlight exactly why we misunderstand the mind-body connection. The medical texts note that physicians frequently prescribe psychotropic medications, specifically certain classes of antidepressants or antiepileptics like gabapentinoids, for fibromyalgia.
Yes, they do.
To a patient, being handed an antidepressant for back and muscle pain feels like the doctor is saying, "It's all in your head, you're just depressed." But that's not what is happening chemically, is it?
Not at all. And it is a massive communication failure in medicine. These specific meditations are not prescribed to treat psychiatric depression in these cases.
Okay.
They are prescribed because they actively intervene in the neurological pain pathways of the brain and spinal cord. Certain antidepressants alter the reuptake of neurotransmitters like serotonin and norepinephrine in the descending pain pathways.
So they change how the signals move.
By doing so, they literally dampen the volume of the pain signals being broadcast to the cortex. They are resetting a misfiring neurological circuit. It is a highly targeted neurological intervention, not a psychiatric dismissal of the patient's suffering.
That distinction is so crucial for patients to understand. But if we pull back from specific conditions like fibromyalgia and look at the psychology of standard, everyday chronic back pain,
Yeah.
we arrive at the single most staggering revelation in this entire body of research. When a patient suffers a severe back injury, you would logically assume that an MRI showing a massive ruptured disc or an X-ray showing severe advanced bone degradation would be the ultimate predictor of how long their pain will last and how poor their recovery will be.
It is the intuitive assumption that massive physical damage equals massive prolonged pain. But the clinical data flatly rejects that logic. Yes. The absolute size of a herniated disc, the severity of the osteoarthritis on the X-ray, the visible state of the bones, none of these radiographic markers have any reliable statistical correlation with the duration or chronicity of a back pain episode.
Zero correlation. The physical damage does not dictate the timeline of the suffering. So what is the predictor?
What's fascinating here is the single most accurate, heavily weighted predictor of chronic back pain, pain that lingers, paralyzes, and ruins a life for months or years, is job dissatisfaction.
I literally had to reread that sentence in the text 3 times. Job dissatisfaction, the feeling of hating your employment, literally prevents your physical, biological tissues from healing. How is that possible?
It returns to the HPA axis and systemic inflammation.
The stress response again.
Exactly. Dragging yourself out of bed every single day to face a job you despise, feeling chronically underappreciated by management, navigating a toxic workplace culture, this creates an unbroken chronic state of psychological distress.
And that releases cortisol.
Yes. That distress keeps cortisol levels perpetually elevated. Chronic cortisol exposure eventually downregulates the immune system's ability to heal tissue while simultaneously keeping systemic inflammation high.
Wow.
This inflammation settles into the weakest mechanical link in the body, which is almost always the lower back. Furthermore, the psychological despair alters pain perception, making the brain hypervigilant to the lingering signals from the initial injury.
And this spirals directly into what the researchers define as the fear avoidance model. This specific statistic is haunting.
It's very revealing.
In evaluated cases of chronic, long-term lower back pain, only 10% of the patient's daily disability is attributed to the actual physical tissue pain. A massive 33% of their disability is directly caused by fears, beliefs, and avoidance behaviors.
The fear of the pain becomes a vastly more destructive force than the physical pain itself.
So what does this all mean? The patient becomes trapped in a psychological prison. They experience a severe spasm, and their brain decides, if I bend over to tie my shoe, my spine will snap. Or if I go for a walk, I will cause irreversible damage.
Right.
So they stop moving entirely. They become terrified of their own physical form. And by freezing up, by retreating to the couch, they cause the paravertebral muscles to rapidly atrophy.
Which makes it worse.
The joints stiffen from lack of synovial fluid circulation. The back structurally degrades further due to the total lack of movement. They are actively causing the exact biomechanical catastrophe they're trying so desperately to avoid.
This specific psychological trap is exactly why the global medical consensus has radically, fundamentally shifted regarding the treatment of acute back pain, particularly the implementation of the 48-hour rule.
What's the rule?
Well, decades ago, if you presented with a severe lumbago, the standard medical advice was mandatory prolonged bed rest. Stay flat for a week or two until the pain stops. Today, the strict evidence-based mandate is absolutely no prolonged bed rest beyond 48 hours maximum.
You have to get up and move. even if every fiber of your being is screaming in pain.
You must resume normal, modified activities as quickly as humanly possible, ideally facilitated by a short course of strong, tapering analgesics.
Why is it so urgent?
The reasoning is deeply neurological. If you remain immobilized in bed for days or weeks, allowing the pain signals to fire unchallenged, a phenomenon known as neuroplasticity turns against you.
Oh, the brain starts wiring itself to the pain.
Exactly. A pathological neurological loop begins to form. The continuous pain signals map themselves permanently onto the somatosensory cortex of the brain. The brain essentially learns the pain, memorizes the pathway, and becomes highly efficient at generating it.
That's terrifying.
It can continue to broadcast that severe pain signal on an infinite loop permanently, long after the physical micro-tear in your spinal ligament has completely healed. The physical injury vanishes, but the neurological ghost of the injury haunts the nervous system indefinitely.
The idea that your brain can memorize pain and torture you with it after the body is healed is terrifying. It makes you realize how vital it is to break that loop instantly.
Absolutely vital.
But let's shift our perspective to the timeline of a human life, because our bodies and our hormones are constantly changing. How much this pain is predetermined by the genetics we are born with? Are some people just doomed to suffer?
The role of heredity is nuanced. You do not inherit a specific back pain gene that guarantees suffering.
Okay, that's good.
What you inherit is anatomical architecture. The structural shape of your spine, whether you naturally possess an exaggerated lumbar lordosis, which is a deep inward sway back, or conversely, a very flat, rigid back, tends to be highly hereditary.
And that changes the physics.
Right. These specific inherited shapes alter the biomechanical leverage we discussed earlier, predisposing certain spinal segments to accelerated mechanical wear. Beyond pure shape, there are highly specific genetic markers linked to devastating inflammatory diseases. The most prominent is ankylosing spondylitis.
What exactly is that?
Ankylosing spondylitis is a severe progressive inflammatory rheumatism that primarily targets the sacroiliac joints, where the base of the spine meets the pelvis and the vertebrae themselves.
That was painful.
Over time, the chronic inflammation can actually cause the vertebrae to fuse together into a rigid column. The clinical data shows this disease is incredibly strongly linked to the presence of a specific genetic marker, the HLA-B27 antigen.
How does possessing one specific antigen multiply your risk so dramatically?
It essentially involves molecular mimicry. The HLA-B27 antigen is a protein on the surface of white blood cells that helps the immune system identify foreign invaders.
Okay.
However, in individuals with this marker, the immune system can become confused, often triggered by a minor gastrointestinal or genitourinary bacterial infection.
Okay.
The immune cells mistake the body's own healthy joint tissue in the spine for the bacterial pathogen and launch a massive continuous attack on the spine.
Oh, wow.
If a parent carries this antigen and suffers from the disease, the risk for their child developing it is multiplied by 5 compared to the general baseline population.
So architecture and immune markers are inherited. But what about the massive hormonal shifts we experience? The clinical observations point out a very stark, highly specific spike in severe back pain consultations for women right around the age of 50.
This correlates directly with the onset of menopause, which is a period of profound systemic physiological upheaval.
What's the main driver there?
The primary driver here is the rapid depletion of estrogen. Estrogen plays a critical protective role in bone metabolism. It actively inhibits the osteoclasts, the cells that break down old bone.
Oh, I see.
When estrogen levels plummet, osteoclast activity accelerates unchecked, leading to a temporary but rapid weakening of bone density and microstructural integrity in the vertebrae.
Plus all the other changes.
Exactly. Simultaneously, the metabolic shifts often lead to a redistribution of body weight, specifically an increase in abdominal adipose tissue. This physically changes the woman's center of gravity, pulling the lumbar spine forward and placing extreme new demands on the paravertebral muscles.
The crane leans forward again.
Right, again. Couple all of that with the sleep disruption and emotional volatility caused by hormonal swings, and you have a perfect storm for acute back pain.
But the incredibly hopeful takeaway from Dr. Delong's analysis is that this is a defined phase. Women hit this terrifying spike in pain at 50, and they understandably assume, oh no, my body is failing. This is the beginning of the end. It will only get worse until I die.
It's a natural fear.
But the data says that is entirely false.
Precisely. It is a 2 to 3 year transitional crucible. Once the female body establishes and acclimates to its new, lower hormonal baseline, and the muscles adapt to the shifted center of gravity, the acute generalized pain typically subsides entirely.
That's amazing.
Which brings us to perhaps the most counterintuitive, expectation-shattering fact in the entire stack of research: the myth of the elderly spine.
Yes, every single person walking the earth assumes that as you get older, your back inevitably gets worse. It's cultural given.
Yeah.
You turn 70, your joints are worn out, ergo, your back must be in constant agony.
It seems like common sense.
But the clinical statistics say the exact opposite is true.
It defies all mechanical logic, but statistically, generalized, nonspecific back pain actually decreases significantly after the age of 50 or 60.
How is that physiologically possible when the joints have sustained decades more wear and tear?
It is a combination of lifestyle and biology. From a lifestyle perspective, individuals in their 60s and 70s are often retiring, drastically reducing the repetitive occupational stressors, heavy lifting, and chronic workplace anxieties that fuel the pain loops we discussed earlier.
Okay, the job dissatisfaction goes away.
Right. But biologically, something fascinating happens to the spine. Remember the viscoelastic discs we talked about? The ones that dehydrate over time?
Lunges, yeah.
By the time you reach advanced age, those discs have lost almost all their water content. They become incredibly stiff, fibrotic, and rigid. While this reduces overall flexibility, it actually makes the spine mechanically more stable. The hypermobility and micromovements that cause the acute, agonizing ligament sprains in 30-year-olds simply cannot happen in a stiffened 70-year-old spine.
The spine basically casts itself in place. So if an elderly patient does present with sudden, excruciating, generalized back pain, doctors cannot just wave it away as old age.
Absolutely not. A clinician presented with new, severe back pain in a 70-year-old must immediately investigate for specific, often serious pathologies.
Like what?
They look for costovertebral arthrosis, a specific form of arthritis where the ribs articulate with the thoracic spine. They screen for metastatic bone lesions, and crucially, they must evaluate the patient for masked depression.
Masked depression. Why would depression look like a back injury?
In geriatric populations, profound clinical depression frequently does not manifest as vocalized sadness, crying, or expressions of hopelessness.
It's physical instead.
Yes, it manifests somatically. The psychic pain is converted entirely into severe, migrating physical pain, most often localized in the spine and the gastrointestinal tract. Treating the physical back in these cases is useless. You must treat the underlying geriatric depression.
However, the texts do acknowledge that the elderly face very real, unique mechanical failures. Even if generalized pain decreases, the structure itself changes.
It does.
After 65, the body undergoes a relentless process called sarcopenia. Sarcopenia is the involuntary, age-related atrophy of muscle mass. The dense, powerful muscle fibers of the paravertebrals are gradually replaced by inert fat deposits and stiff connective tissue like collagen.
It's a significant loss.
A senior can easily lose up to a third of their total muscle strength without changing the routine.
Returning one last time to our crane analogy, if the massive steel cables holding the crane upright are made of muscle, and those cables slowly turn to soft fat and weak string,
The crane begins to lean. It has no choice.
the spine loses its muscular guy wires, it lacks the strength to fight gravity, leading directly to the hunched, deeply kyphotic posture we associate with extreme old age.
And their bones are changing too, right?
Yes. When you combine the severe muscular weakness with osteoporosis, where the bones lose their dense calcium matrix and become hollow and brittle, the results are silent and devastating.
The microfractures.
Exactly. The daily force of gravity causes hundreds of microscopic microfractures within the vertebrae. These tiny fractures cause the vertebral bodies to gradually, painlessly compress and flatten. Over a decade, an elderly individual can silently lose up to 10 centimeters in total height, entirely unaware that their spine is slowly collapsing in on itself.
It paints a vivid picture of a structure under constant siege, which leads us to the final frontier of our deep dive. If the muscles are destined to fade, if the bones are compressing, and if the brain is constantly trying to trap us in fear avoidance loops,
We have to defend ourselves.
exactly. Our only defense mechanisms are how we choose to move, how we fuel our bodies, and how we navigate the medical-industrial complex. Let's start with the most basic human movement, sitting. We have all been aggressively scolded by parents and teachers to sit up perfectly straight. It is a concept deeply rooted in Victorian morality, the idea that a straight spine equals a strong moral character.
And from a strictly biomechanical and ergonomic perspective, it is Horrendous advice.
Seriously.
Yes. Forcing the human spine into a rigid, perfectly straight, upright line while seated requires constant, maximum isometric contraction of your core and paravertebral muscles.
Isometric meaning.
Isometric contraction, where the muscle is firing forcefully but not changing length, exhausts muscle tissue incredibly rapidly. It starves the muscle of oxygen, leading to lactic acid buildup, profound fatigue, and ultimately severe pain.
So the posture we were taught is perfect is actually guaranteed to cause injury. What is the actual clinical ideal posture for someone trapped at a desk for 8 hours?
The clinical answer is remarkably pragmatic. The best posture is simply the one that causes zero pain, period.
That's it.
That's it. A slightly slouched, relaxed, asymmetrical position where your muscles can actually disengage and rest upon the ligaments. And the chair support is vastly superior to rigidly forcing an unnatural military posture.
Wow.
Furthermore, the human body is inherently asymmetrical. Having one shoulder slightly higher than the other or a slight pelvic tilt is entirely normal. Attempting to forcefully correct that natural asymmetry to achieve perfect visual alignment can actually trigger new pain cascades.
So what should office workers do?
The ultimate ergonomic key is not a perfect static position, but relentless movement. Shifting, slouching, standing, leaning, constantly changing the load distribution is what keeps the discs hydrated and the muscles oxygenated.
Speaking of movement, the clinical insights from Dr. Delong are incredibly specific about choosing the right sports if you are prone to back pain. We assume all exercise is good exercise, but if your spine is compromised, certain popular sports are essentially torture devices.
They are. If you suffer from disc degeneration or osteoarthritis, high impact and high torsion sports are your absolute enemies.
Like running.
Running on pavement sends a violent repetitive shockwave traveling straight up the tibia, through the femur, and directly into the lumbar spine with every single footfall.
Yikes.
Sports like squash or tennis demand violent, explosive torsions of the spine while fully extended, maximizing the shear forces that tear spinal ligaments. Golf, biomechanically speaking, is an asymmetrical, high-velocity twisting mechanism that places catastrophic torque on the L5-S1 disc.
But the clinical data highly recommends cycling and swimming. Why are those the gold standards?
Cycling is phenomenal because it is entirely low impact. The seat supports the bulk of the body weight, entirely removing the vertical compressive force from the lumbar spine, while the pedaling motion actively engages the abdominals and the psoas muscles, which stabilize the pelvis.
And swimming.
Swimming is excellent, but with a major caveat. You must utilize the front crawl or the breaststroke with the head submerged.
Why submerged?
This keeps the spine in a perfectly neutral horizontal axis, supported entirely by the buoyancy of the water. If you swim the breaststroke with your head craned out of the water to keep your hair dry, you are hyperextending the cervical spine and will trigger severe neck spasms.
And for the senior demographics we discussed, the ultimate recommended cure is the simplest: brisk walking. It isn't just about cardiovascular health, it's a mechanical necessity.
Yes, Wolff's Law.
Right. When a senior walks briskly, swinging their arms and legs, the muscles pull rhythmically on their insertions along the spine. This constant mechanical tugging is exactly what the bone needs. According to Wolff's Law, bone adapts to the loads placed upon it.
Exactly.
That pulling stimulates the osteoblasts to rapidly build new, healthy, dense bone tissue. Brisk walking is literally a virtuous cycle of anti-aging for the skeletal system.
And we cannot ignore how we fuel that system. The texts briefly touch upon diet, but the implications are profound. Conditions involving severe caloric restrictions, such as anorexia nervosa, or even the profound loss of appetite common in deep old age, do more than just cause weight loss.
What do they do?
When the body is starved of adequate caloric and nutritional intake, the endocrine system shuts down the production of growth hormone to conserve energy.
Oh no.
Without growth hormone, the skeletal system goes into starvation mode. The osteoblasts cease functioning, the bones plummet in calcium density, and the connective tissues lose all their elasticity. You literally have to eat to fuel the structural integrity of your bones.
Now let's step outside the body and look at the massive apparatus surrounding it, the medical and occupational system. When a patient breaks down and enters the medical machine, how does a doctor actually know what to do? The Kinexa Formation insights delve deeply into the concepts of EBM, evidence-based medicine, and ASMR, amelioration du service medical rendu.
Which is the French metric for evaluating the actual provable clinical benefit a drug or treatment provides compared to existing therapies.
Right. These frameworks exist to ensure that medicine is driven by empirical science rather than tradition or guesswork. They rely on massive, double-blind clinical trials to definitively prove whether a muscle relaxant or a surgical intervention actually alters the outcome of a spinal pathology.
That's the theory, yes.
But here's the statistic that completely derailed my understanding of modern medicine. Despite all the rigid protocols of evidence-based medicine, the clinical data reveals that a staggering 79% of medical care acts for back pain are not based on rock-solid, explicit scientific
That's
proofs.
a huge number.
Only 21% of what happens in a clinic is irrefutably backed by hard science. So what on earth is driving the other 79% of our recovery?
This raises an important question, right? And the answer is trust. The profound power of the therapeutic alliance.
The relationship with the doctor.
Exactly. Because back pain is so intrinsically entangled with psychology, fear avoidance, stress, and lifestyle, the clinical effectiveness of any given treatment, whether it's a specific physiotherapy stretch, an acupuncture needle, or a mild analgesic, relies heavily on the placebo effect and the patient's absolute belief in the care they are receiving.
Wow.
If a doctor takes the time to listen, to validate the suffering, and to clearly explain the benign realities of the pain, the patient's neurological threat level drops. The parasympathetic nervous system engages, cortisol plummets, and the muscles physically relax.
Yeah.
The trust in the practitioner is often the most potent active ingredient in the entire treatment plan.
That is a beautiful, if slightly terrifying reality about how our brains control our healing. But the system isn't just medical, it's occupational. In France, where these specific frameworks originate, the occupational health system plays a massive, legally binding role in back pain. It can actually be legally classified as a professional disease.
Yes.
The occupational doctors rely on incredibly specific bureaucratic charts, namely Table 97 and 98 of the Social Security Code.
Yes, the system recognizes that labor can destroy the body, and it offers compensation. But the criteria for proving that your job broke your back are brutal and incredibly rigid.
You can't just say your chair is bad.
No, you cannot just claim your back hurts from your desk chair. To qualify under Table 97 or 98, you must have an MRI proving a very specific L4, L5, or L5S1 herniated disc, and D, that herniation must be actively compressing a nerve root with matching clinical symptoms.
That's specific.
Furthermore, you must provide documented proof that you are exposed to specific severe mechanical stressors, like heavy, repetitive manual lifting, or exposure to intense whole-body vibrations from driving a heavy loader or a tractor for a minimum of 5 continuous years.
It is an incredibly high bar to clear, and the data notes that in cases of extreme chronic severity, patients can be granted ALD 30 status, an affection de longue durée which provides 100% Social Security coverage for all treatments related to their spine.
Right.
But the reality of trying to save a career after the spine fails is unbelievably grim. So if someone has to go on half-time therapeutic leave, does it actually save their career? I read this final statistic, and it is heartbreaking. If a blue-collar worker goes through the grueling process of professional reclassification, meaning the state deems them medically unfit for their physically demanding job and attempts to retrain them for sedentary desk work, what are their chances of survival in the workforce?
The clinical and socioeconomic data shows that only 10% of those reclassified workers successfully secure and maintain new employment.
Only 10%.
90% drop out of the workforce entirely, slipping into long-term disability, financial ruin, and the accompanying profound depression.
10%. A catastrophic back injury doesn't just fracture a vertebra, it shatters a livelihood. It completely destroys the socioeconomic foundation of a family.
Which is exactly why the early interventions we have spent this hour discussing are not just medical advice, they are socioeconomic imperatives.
Absolutely.
Understanding the mechanical leverage, conquering the fear avoidance loop before it paralyzes you, maintaining mobility, and finding a way to mitigate job dissatisfaction are critical defense mechanisms against a total collapse of a patient's life.
We have covered an absolutely monumental amount of ground today. We started with the realization that back pain isn't a modern failing, but a historical, elegant complaint.
Right.
We mapped out the terrifying physics of bending over a sink, the shocking reality that 30% of us have silent herniated discs, and the fact that anti-inflammatories are treating the swelling, not the structural bulge. We learned that the brain can memorize pain, that an anxious mind keeps muscles clenched all night long, and that hating your boss is a greater threat to your spine than lifting a heavy box.
It requires a profound fundamental shift in how we view ourselves. We have to move away from a purely mechanical, structural view of the body where we are just machines with broken gears and embrace the biopsychosocial model.
Everything is connected.
The spine is the intersection of our anatomy, our psychological state, and our social environment.
But before we officially sign off, there is one final, lingering mystery buried deep in the clinical research. A phenomenon we all know, we all talk about, and we all believe. Something for you, the listener, to ponder the next time your joints begin to ache. We have to address the weather myth.
Ah, yes. The millions of human barometers walking among us.
Exactly. I know people, and you know people, who will swear on their lives that their bodies can predict an incoming storm better than any meteorologist. They feel the dampness in the air, the temperature drops, and their arthrosis immediately flares up in agony.
Oh, yes.
They will tell you that a week on a sunny beach cures their sciatica, and the month of November brings it roaring back. It is a universally accepted human experience.
It is universally accepted, and yet clinical science has put this exact phenomenon to the test, using incredibly rigorous methodologies. Researchers have conducted long-term prospective studies where patients meticulously log their daily pain levels in diaries, while the researchers track the exact minute-by-minute meteorological data.
Right, measuring subtle barometric pressure drops, ambient humidity levels, temperature fluctuations, and total sunlight hours. And what did the massive collision of this data reveal?
Absolutely zero correlation. Nothing. Mathematically and scientifically, the weather does not alter joint pain.
That a profound, almost jarring clash between deeply felt human experience and cold clinical data. Wait, really? How can millions of people feel something so acutely that science says isn't happening?
It highlights the sheer power of human pattern recognition and the biopsychosocial model we just discussed. Perhaps the summer sun cures their back pain, not because of the barometric pressure, but because they are on vacation. They're finally away from the toxic jobs they despise, walking on the beach and sleeping without stress. Perhaps the damp winter brings agonizing pain, not because of the cold, but because the cold forces us to huddle indoors, unconsciously tensing our neck and shoulder muscles against the chill, while succumbing to the lethargy and depression of the winter blues.
That makes so much sense.
The mind and the body are entirely inseparable. We project our seasonal moods onto our physical joints.
So keep that in mind the next time you find yourself blaming the rain clouds for your aching back. Take a moment to pay attention to your posture. Check in on your stress levels. Assess how you really feel about your daily grind. And sure, check your weather app if you want to, but always keep questioning what you think you know about your own body. Because when it comes to the human spine, nothing is as simple as a jagged white line on an X-ray. It is not binary. It is messy. It is deeply psychological. It is biomechanically wondrous, and it is fundamentally human. Thank you for taking this deep dive with us.